Good morning, everyone. Welcome. And on behalf of Screen and Jay and the Rutgers Cancer Institute, welcome to Community Cares and Project Echo. Thank you for joining today's session, and we hope that the information shared today will help you serve your community better. And now, just a few announcements before we begin the presentation. The information contained in this presentation is not a substitute for medical consultation. A physician should always be consulted for any health problem or medical condition. For today's agenda, we will have our Project Echo overview, our introductions, the presentation, the case study, and then our Q&A forum. So the Rutgers Cancer Institute became a Project Echo hub in 2021. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The ECHO model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. And this is done by using technology to leverage scarce resources. So we're sharing best practices to reduce disparities, applying case-based learning to master complexity, and evaluating and monitoring outcomes. For more information on Project ECHO, visit echo.unm.edu, and UNM is University of New Mexico. So, our introductions to our fabulous speakers today. We have our own Lauren Johnson, who is a CHES and a community cancer control specialist at Rutgers Cancer Institute. She has over 8 years of public health experience. She obtained her Bachelor's of Science in Public Health at Montclair State University and is a certified health education specialist. Lauren has worked in a variety of public health settings, and her experience focuses on community and patient education, cancer screening and prevention, reproductive and sexual health education. Today we have Dr. Lisa Gabor joining us, and she completed her Bachelor of Science in Biomedical Engineering at the George Washington University in Washington, D.C. She was then a postbaccalaureate research fellow at the National Institutes of Health in Bethesda, Maryland, and she attended medical school at Rutgers Robert Wood Johnson Medical School in New Brunswick. Before completing her residency training in obstetrics and gynecology, at New York Presbyterian Columbia University Irving Medical Center in New York. Dr. Gabor completed her fellowship in gynecologic oncology at Montefiore Medical Center, Albert Einstein College of Medicine in New York, and is board certified in both obstetrics, I can't say that, sorry guys, and gynecology, as well as gynecologic oncology. In her current role as assistant professor, she proudly provides comprehensive care for patients with concerns or diagnoses of cancers of the female reproductive tract. In addition to being actively involved with medical student and residency education and training, she also serves as the associate program director for the fellowship training program in gynecologic oncology at Rutgers. Nationally, she participates in committees and organizations such as the Society of Gynecologic Oncology and the American Society of Colposcopy and Cervical Pathology. Thank you both for joining us today, and I'm going to hand it over to Lauren.
Thank you, Evelyn. Thank you, everyone, for coming on today and taking the time out to listen to some information about infectious agents. So now we are going to get started with a pretest. And so you should see that a pretest just popped up on your screen, and there are 4 questions about infectious agents. So please take a moment to read through each of the questions and answer whether or not you believe that they are true or false. And if you aren't sure about any of the answers, that is okay. Feel free to go ahead and take a guess. Throughout today's presentation, we will be reviewing the information, so you'll receive the answers. And after we finish the presentation, we will also have a post test as well to assess all of the information that you have learned.
And Lauren, we'll just give it about another minute to to give time for more people to finish the poll. I'm going to move on to the next slide.
Okay. And so now we have an overview of each topic that we'll be discussing today in infectious agents. So, first off, we will be talking about human papillomavirus, also known as HPV. After that, we will be discussing herpes. Following herpes, we have human immunodeficiency virus, also known as HIV. Following that, we have hepatitis B and hepatitis C. We also have Epstein-Barr virus, known as EBV. We have H. pylori, which we'll talk more about, as well as Merkel cell polyomavirus. And now we will review what human papillomavirus or HPV is. What is HPV? HPV, also known as human papillomavirus, as discussed, is the most commonly transmitted STI in the United States. HPV can be transmitted through intimate skin to skin contact, such as vaginal, anal, and oral sex. The virus can also be spread by genital contact, even without having penetrative sex. This includes oral to genital as well as hand to genital spread. HPV is passed from one person to another during skin to skin contact with an infected area of the body. And contrary to popular belief, practicing safer sex alone will not completely prevent a person's risk for HPV. And we'll talk shortly about the HPV vaccine, which is known as the most effective way to prevent HPV. So now we'll discuss some of the HPV strains and risks. So there are more than 200 different types of HPV, and these are split into two categories, and they're known as high risk as well as low risk HPV. High risk HPV is called high risk because it can lead to the development of certain cancers, which include cervical cancer, vulvar cancer, anal, oral, and penile cancer, as well as others. And there are approximately 13 different high risk strains of HPV. And then we have low risk HPV, which is called low risk because it is not cancerous, but it can cause warts on the body as well as other symptoms. And HPV type 16 and 18 are mostly responsible for HPV related cancers. HPV affects nearly all sexually active people, regardless of their number of sexual partners, their sexuality, as well as their gender identity. And reducing the number of sexual partners can reduce a person's risk, but it is important to keep in mind that a person can still be infected by only one partner. There are approximately 13 million Americans, including adults and teens, that become affected annually with HPV. And every year in the US, HPV causes approximately 36,000 cases of cancer in men and women. And now we have some information about how HPV can lead to cancer. Once high risk HPV, such as HPV type 16 or 18 that we mentioned, infects the cells, it interferes with the ways in which these cells communicate with one another, and it causes the infected cells to multiply in an uncontrolled manner. These infected cells are usually recognized and controlled by the immune system, which defends the body against the affected cells. However, sometimes these infected cells do continue to remain in the body and grow, and they can form an area of precancerous or abnormal cells that haven't spread, but if not treated through monitoring, surgery, immunotherapy, and things of that nature, can cause the cells to become cancerous. And as a result, research has found that it can take approximately 10 to 20 years, sometimes even longer, for HPV infected cells to develop into cancerous tumors in the cervix. And here we have examples of some of the types of cancer that can develop from HPV. So as we can see, there is cervical cancer, there is also anal cancer, oral cancer, vulvar cancer, vaginal cancer, and penile cancer. And now we'll talk about ways we can prevent HPV. So, prevention is always better than treatment. The ultimate goal in medicine is to prevent cancer or prevent disease from occurring. And the HPV vaccine is one way that we prevent cervical cancer from occurring, as well as other HPV attributable cancers, such as oral cancer or anal cancer or cancer of the vagina, for example, which we just mentioned. So, HPV vaccination can prevent more than 90% of cancers caused by HPV from ever developing. Condoms are another type of sexual protection that can be used to protect against HPV, but it does not protect 100% from acquiring HPV. The HPV vaccine is the most effective form of prevention. And the vaccine protects against 9 different types of HPV that are most likely to cause genital warts and cancer. And here we have a breakdown of the vaccine schedule for the HPV vaccine. So it is recommended for all children, boys and girls, to get the HPV vaccine between the ages of 9 to 12 in 2 doses over the course of 6 months to a year. And the New Jersey HPV Vaccination Action Team, which is a subgroup of the New Jersey State Cancer Coalition, is leading a call to action to recommend that the HPV vaccine be administered at age 9 instead of age 11. If the vaccine is administered to persons over the age of 15, they would receive 3 doses instead of two over the course of 6 months. And catch-up vaccinations are also available too for people over the age of 26 who are interested in receiving the HPV vaccine. And it is also approved for safety throughout the ages of 45 who were for people who were not adequately vaccinated. So if a person is between the ages of 26 and 45 and they are interested in receiving the HPV vaccine, or say they've gotten 1 dose out of the series and they can't remember if they've received any other doses, then they are also eligible for the catch-up vaccination. And now we will talk about methods of treatment as well as screening for HPV. So first up, we have the cervical pap. So the cervical pap is not an HPV test. And during the cervical pap smear, a healthcare provider will gently take a sample of cells from the cervix using a small brush and then review the cells under a microscope. This screening exam checks for cancers or precancerous cells of the cervix, and contrary to popular belief, this does not test for HPV. And it's important to talk with a healthcare provider on when to begin receiving routine pap smears. Next up, we have the LEAP procedure. So there's often question about whether or not HPV can be treated. And although the HPV infection itself cannot be treated, there are treatments for the precancerous cell changes caused by infections with high-risk HPV. Precancerous cervical cell changes can be removed by the loop excision procedure, which removes abnormal tissue by heating a wire loop to remove the abnormal cells. There are treatments for other precancerous vaginal, vulvar, or penile cells, as well as anal lesions and genital warts. Treatment methods include topical medicines, surgical excision, other surgeries, as well as laser therapy. And it's important to talk with the healthcare provider about the best treatment options. And next up, we have the colposcopy. In some cases, if there is an abnormal pap smear result, or there are symptoms of cervical, vaginal, or vulvar cancer, a person may have a colposcopy done to detect signs of the disease. During this procedure, a magnifying instrument called a colposcope is used to observe the cervix, the vagina, and the vulva and confirm a diagnosis, identify the location of abnormal cells, and determine how advanced the abnormal cells are. And now we have the HPV test. The HPV test looks for cervical infection by high risk types of HPV that are more likely to cause precancers and cancers of the cervix. The test can be done by itself or at the same time as the pap test, and this is known as a co-test. And this can be done using the same swab or a second swab to determine a person's risk of developing cervical cancer. There are currently no approved HPV tests for males, and it is still recommended that males receive the HPV vaccine. And now we have screening for other HPV related cancers. First up, we have anal cancer as one of the HPV related cancers. And there are no official anal cancer screening guidelines, but it is recommended that people discuss with their healthcare providers getting anal cancer screening if they are considered a high risk group. And that could include if they are people with a history of receptive anal sex, including men who have sex with men, people who have a history of cervical or vulvar cancer, people living with HIV, people with organ transplant history, and experts recommend an anal pap smear every 1 to 2 years among the HIV positive population. And the anal pap smear is a procedure where a doctor will use a Q-tip to take a sample of cells from the lining of the anus while the patient lies on their side. And similar to the cervical pap, the anal pap checks for cancerous or precancerous cell changes. And in addition to that, we also have oral cancer. So there is no official screening test for oral cancer, and some dentists will examine the entire mouth to check for oral cancers early, but it is recommended that patients do observe any abnormal changes in their own mouths. So that includes any white patches, any sores, or any lumps. And now we are going to discuss herpes. Herpes is a common viral infection known for causing painful blisters or ulcers on the skin and mucous membranes. It is treatable, but not curable, and once a person is infected, the virus remains in the body for life. There are two types of herpes, known as HSV1 or herpes simplex virus type 1, and this type is most commonly transmitted through oral contact and commonly causes oral herpes, also known as cold sores. And it can also result in genital infections, especially through oral to genital contact. Most adults are infected with HSV1, often during childhood. And then we also have HSV2, also known as herpes simplex virus type 2. And this is primarily spread through sexual contact and is the leading cause of genital herpes. After the initial infection, the virus lies dormant in the body and can reactivate periodically. It is important to remember that herpes is treatable, not curable, as mentioned. And here we have some risk factors for each type of herpes that we just mentioned. And so some of the risk factors include unprotected sexual contact, and this could be sexual contact to the vagina, the anus, or oral sex. And this increases a person's risk for both HSV1 and HSV2. And then we also have, as another risk factor, people with a history of other STIs or sexually transmitted infections. Having other STIs increases a person's susceptibility to HSV due to disruptions of the mucous membranes. Type 1 also has signs and symptoms that include fever, headache, muscle aches, and swollen lymph nodes, especially in the neck. And type 2 has symptoms that include itching or discomfort in the genital region, as well as swollen lymph nodes in the groin. And here we have information about how herpes can lead to cancer. Both herpes type 1 and 2 are double-stranded DNA viruses from the herpes family, and they are capable of persisting in the body by entering a latent phase in the nerve cells. Herpes type 2 has been linked to an increased risk of cervical cancer, particularly when co-infection with human papillomavirus or HPV, which we just discussed, is present. HSV or herpes may also increase the risk for anal precancerous lesions and can be associated with head and neck cancers. Herpes association with cancer stems from the ability to disrupt cellular DNA repair and enhance cancer genes, which promotes the development of tumors. And now we have risk reduction methods for herpes. In order to reduce a person's risk for herpes, it is important to get tested for herpes, and that includes viral cultures or samples from a sore that is cultured to detect the live virus. It also includes PCR tests, which detects the herpes DNA from lesions, blood, or from spinal fluid. There are also blood tests to detect herpes type 1 or herpes type 2 and their specific antibodies. It's also important to avoid sexual contact during outbreaks, limit the number of sexual partners a person has, use condoms, take daily antiviral medication, which is suppressive therapy, known to suppress the virus, get tested and know a person's herpes or HSV status, avoid sharing personal items, so that includes lip balms, utensils, cups, and things of that nature, as well as practicing good hand hygiene, so washing hands as well. And we did mention some of the types of screening for herpes, but again, to reiterate, there are viral cultures to test for herpes, there are PCR tests and blood tests that detect antibodies. And these methods help to confirm the diagnosis and distinguish between herpes type 1 and herpes type 2. And while there is no cure for herpes, antiviral medications can be administered and they are effective at reducing the frequency and severity of outbreaks. And they also help to lower the risk of transmission from from the person with herpes to others. And preventative strategies such as condom use and avoiding sexual contact during outbreaks are other methods of preventing the spread of herpes. And now we will discuss what HIV is. HIV stands for human immunodeficiency virus, and HIV is a virus that attacks the body's immune system. Without treatment, it can lead to AIDS, which is known as acquired immunodeficiency syndrome. In the US, over 38,000 people received a new HIV diagnosis, according to the CDC in 2022. HIV can be transmitted through intimate skin to skin contact, which includes vaginal and anal sex. Most people who get HIV usually acquire it through anal or vaginal sex, sharing needles, syringes, or other drug injection equipment. And only certain bodily fluids can transmit HIV. And these bodily fluids include blood, semen, preseminal fluid, also known as precum, rectal fluids, vaginal fluids as well. And in order for transmission to occur, these fluids must come in contact with a mucous membrane or damaged tissue by directly being injected into the bloodstream from a needle or syringe. A person's viral load, other STIs, and alcohol or drug use can also increase a person's chances of getting as well as transmitting HIV. And here we have information about how HIV can lead to cancer. So HIV weakens the immune system by destroying CD4 cells, and a weak immune system can't fight off abnormal or cancerous cells effectively. With low immunity, people with HIV are more likely to get infected with other cancer-causing viruses, such as HPV or human papillomavirus, EBV, also known as Epstein-Barr virus, HHV, 8, or hepatitis B and C. These viruses can lead to cancers such as cervical cancer, Kaposi sarcoma, and liver cancer. And sometimes the infected cells continue to grow, which cause them to eventually form an area of precancerous cells that, if not treated, can become cancerous. And here we have risk factors for HIV and AIDS associated cancers. Risk factors for HIV include unprotected sex, especially anal or vaginal sex without a condom, multiple sexual partners, or having a partner with an unknown HIV status, sharing needles or injection drug equipment, having another sexually transmitted infection, which can increase a person's susceptibility, lack of access to preventative measures such as PrEP, which we will discuss in the next slides, and regular testing. And risk factors for HIV associated cancers include a weakened immune system, co infection with cancer causing viruses such as human papillomavirus, Epstein Barr virus, or hepatitis B and C, smoking and tobacco use, chronic inflammation from ongoing immune activation, and inconsistent or no use of antiretroviral therapy. And here we have information about HIV prevention medication and activities. PrEP is a medication that is taken before being exposed to HIV and can be used by adults, adolescents, and pregnant people without HIV. PEP is another type of medication that can be used, and this is primarily used to prevent HIV from developing after a person has been exposed to HIV. Regular testing allows you to remain aware of your present health status. And condoms are another type of prevention activity that can be used to provide some protection against HIV, although they don't completely prevent HIV infection or exposure. And now we are going to transition into hepatitis B and hepatitis C. Hepatitis B is a viral infection that is contagious and can be spread through bodily fluids or blood, such as needle sharing activities. Hepatitis B is primarily spread when blood, semen, or certain bodily fluids, even in small amounts, are spread from a person infected with HPV to a person who is not infected. And approximately 1 in 2 people with hepatitis B do not know that they are infected. There are two types of hepatitis B, and they can be classified as either short term or long term. And short term hepatitis B is known as acute hepatitis B. And this is a short term illness that occurs within the first 6 months after exposure to hepatitis B. Chronic HPV occurs once the virus has been present for 6 months or longer. If symptoms occur during acute infection, they often begin 90 days after exposure. And again, acute HBV is exposure that has occurred within 6 months, or infection rather, that has occurred within 6 months of exposure. So symptoms usually occur within 90 days after a person has been exposed. And although the symptoms of acute HPV infection and chronic HPV may be similar, most people with chronic HPV do not have symptoms until much later in life, often decades after exposure. And these symptoms, even if they do occur later in life, can include dark urine or clay-colored stools, jaundice, which is yellowing of the skin or eyes, fever, feeling tired, as well as loss of appetite. And then here we have some fast facts about hepatitis B. Long-term HBV can also increase an individual's risk of cirrhosis. Approximately 640,000 adults in the United States have chronic HPV, as well as HBV in some cases can be accompanied by HIV. How does HBV lead to cancer? Chronic HBV is one of the leading causes of a main type of liver cancer called hepatocellular carcinoma and liver cirrhosis in the United States. This virus contributes to cancer development through several mechanisms, including integration of hepatitis B DNA into the host cell's DNA, which causes genetic mutations in cancer-related genes and the mutation of these damaged cells. And over time, if the damaged cells are untreated, they can grow into a group of abnormal cells that may turn into cancer if not treated. And here we have information about the hepatitis B vaccine. Hepatitis B is preventable, and the hepatitis B vaccine has been developed to prevent liver infection that causes cirrhosis, liver cancer, and death caused by the hepatitis B virus. It is recommended that all medically stable infants receive the hepatitis B vaccine, and adults between the ages of 19 and 59 who are at risk of developing HBV or want to be protected should also receive the vaccine if they have not. And now we have information about hepatitis C. Hepatitis C is transmitted through blood, and hepatitis C is an inflammation of the liver caused by the hepatitis C virus and can result in cirrhosis and liver cancer, similar to hepatitis B. Similar to HBV or Hep B, there are both acute and chronic stages, and there is no vaccine for hepatitis C, but there are treatments that cure most people. Most treatments involve 8 to 12 weeks of oral medication or pills, and treatment cures approximately 95% of patients with hepatitis C, usually without side effects. And here we have some signs and symptoms for hepatitis C. In many cases of hepatitis C, result in people that are asymptomatic until liver damage occurs. And once that does happen, some of the signs and symptoms of hepatitis C include fever, fatigue, jaundice, and nausea, just to name a few. And here we have information about how HCV can lead to liver cancer. Similar to HBV, chronic hepatitis C, or Hep C, is known to increase a person's risk of liver cancer through inflamed and damaged liver cells that can cause cell mutations. These mutations make the liver more vulnerable to disease and infection. These damaged cells can grow uncontrollably, causing liver cancer. And here we have some risk factors for hepatitis C as well as hepatitis B. So these include co-infection of diseases, tobacco smoking, obesity, which can make screening more difficult, alcohol use, needle sharing, as well as sexual partners. And now we have screening and risk reduction methods for hepatitis B and C. Risk reduction for Hep B and Hep C includes safe practices to reduce or avoid exposure, such as blood tests to screen for hepatitis B and C, receiving the hepatitis B vaccine, using safe sex practices, as well as hand washing. For hepatitis B, there is no medication to treat acute hepatitis, but doctors may recommend resting in fluids. And chronic hepatitis B treatment includes medication to prevent liver disease. There is no vaccine for hepatitis C. However, most treatments for hepatitis C do involve 8 to 12 weeks of oral medication. And again, as mentioned, treatment does cure more than 95% of patients with hepatitis C, usually without any side effects. And now we'll discuss what EBV or Epstein-Barr virus is. Epstein-Barr virus, or EBV, is known as human herpes virus 4, and it spreads mainly through saliva, but can also be transmitted through blood and sexual contact. Most people get infected at some point in their lives, often without realizing it, since the virus can stay dormant in the body and reactivate later on. In some cases, Epstein-Barr virus is linked to mononucleosis, also known as the kissing disease, and it's also linked to certain cancers, which includes nasopharyngeal carcinoma, which is a type of throat cancer that is rare but common in East Asia. It also includes Burkitt lymphoma, which is a type of blood cancer seen in mostly sub-Saharan African regions. It also includes Hodgkin's lymphoma, which is a type of cancer of the lymphatic system, and forms of stomach cancer. Epstein-Barr virus does not always lead to cancer, but understanding potential risks can help with early detection and prevention. Epstein-Barr virus is very common, and approximately 95% of adults worldwide have been infected at some point in their lives with EBV. Infection rates are also influenced by socioeconomic factors, with higher prevalence seen in larger households, lower income families, and children whose parents have lower levels of education. In the United States, approximately two-thirds of children and adolescents between the ages of 6 and 19 have been exposed to EBV. 85% of Mexican Americans test positive for EBV. This is higher than the rates found in non-Hispanic Black and non-Hispanic white populations, where rates are around 83% and 56% respectively. Mexican American populations tend to experience a higher prevalence due to a combination of factors, including social determinants of health. And these differences are influenced by various factors, which include socioeconomic status, household income, parental education levels, which can affect a person's exposure as well as their immune response to the virus. And now we have some of the signs and symptoms of EBV. These include fatigue, fever, inflamed throat, swollen lymph nodes in the neck, and people who get symptoms from EBV, usually teenagers or adults, typically improve with 2 to 4 weeks. And now we have prevention, testing, and treatment. To prevent the spread of EBV, that includes practicing good hand hygiene, avoiding the sharing of personal items, which includes cups, toothbrushes, and things of that nature, as well as limiting or avoiding close contact with infected individuals. People with weaker immune systems should be especially cautious. There are different types of testing for EBV, and that includes several blood tests to detect any antibodies for EBV. These can indicate whether someone has an active or past infection. However, some people may carry antibodies without showing any signs of illness. And most people do improve within 2 to 4 weeks, and doctors can provide medications for pain and fever associated with EBV. And now we'll talk about H. pylori. Formerly known as Helicobacter pylori H. H. pylori is a bacterium that can colonize and infect the stomach lining. It is the most common chronic bacterial infection in humans. However, it does not cause illness in most people. Chronic H. pylori infection leads to inflammation and progressive damage to the gastric mucosa, which is the formal name for the stomach lining. This can lay the groundwork for serious gastric diseases, including stomach cancer. H. pylori is considered a group 1 carcinogen because it is known to cause cancer by triggering persistent immune response, which can cause prolonged inflammation, and that can contribute to structural change and cellular damage, which can eventually progress into cancer. Gastric adenocarcinoma is the most common form of stomach cancer linked to long-term H. pylori infection. And we have some risk factors for H. pylori. And H. pylori is most commonly transmitted through person to person, typically oral to oral or fecal to oral routes, and it can be found in saliva, feces, and plaque on the teeth. This means that there are a couple of ways in which someone may contract H. pylori, and that includes close contact with saliva, vomit, or feces from an infected person. So it is important to be cautious when sharing utensils or things of that nature with others. And although less common than person to person transmission, H. pylori can also be contracted through consumption of contaminated food and water because it can survive in unsanitary conditions. So it's important to be cautious when drinking untreated water or food that has not been properly treated. Other risk factors for H. pylori do include living in crowded conditions in areas with poor sanitation, as you are in close proximity to others. This is especially seen in developing countries. And here we have some signs and symptoms. Most people infected with H. pylori will not have any symptoms, and symptoms typically start to appear when the infection leads to the development of sores or peptic ulcers in the stomach. Only about 10 to 15% of people infected develop these ulcers, and small ulcers may not even cause symptoms. And here we have information about how H. pylori leads to stomach cancer. As mentioned earlier, the most common type of stomach cancer caused by H. pylori is gastric adenocarcinoma, and approximately 95% of all stomach cancers is gastric adenocarcinoma. Chronic H. pylori infection can trigger an immune response that does not go away, which causes sustained inflammation in the lining of the stomach. As the inflammation is sustained over time, it can cause damage to the stomach lining, leading to the formation of ulcers or open sores and gastritis or inflammation of the stomach lining. Left untreated, these ulcers and gastritis can evolve into cancer. And now we have risk reduction methods for H. pylori. A person can reduce their risk for H. pylori infection through practicing good hygiene, which includes hand washing when preparing or handling food, after using the bathroom, as well as after touching a number of different surfaces. It also includes consuming a diet high in fruits and vegetables and low in salted, smoked, or pickled foods, which can help reduce a person's risk. Tobacco cessation is also key to reducing risk for stomach cancer if a person is infected with H. pylori, as well as reducing the amount of alcohol they drink. It's a good idea to get tested for H. pylori, especially if you are experiencing stomach issues that may be linked to an H. pylori infection, or if there is a family history of gastric cancer or H. pylori infection. Lastly, if you find out that you are living with an H. pylori infection, it's important to finish any medication that is prescribed from a healthcare provider. and that includes antibiotics and acid reducing drugs so that the infection can be fully treated. And from here, we are going to transition into Merkel cell polyomavirus. Merkel cell polyomavirus is a human virus that is known to cause or promote the development of a rare type of skin cancer called Merkel cell carcinoma. It causes a skin infection with a long-lasting infection, and it can end up replicating and existing within human cells, specifically the Merkel cells. And these are found in the deepest layer of the epidermis, which is the outermost layer of the human skin. This virus is very prevalent in the general population, although most people do not experience symptoms. 90% of adults have antibodies against Merkel cell polyomavirus, which indicates a prior infection at some point in their lifetime. An infection typically occurs early on in life, with infants and children being exposed to the virus, typically from their family or peers. There is no definitive route of transmission that has been proven, but researchers have discovered that the virus is detectable within the skin, as well as in respiratory samples and samples in the urine and blood. Merkel cell carcinoma is a rare and highly malignant form of skin cancer that arises in the Merkel cells located in the deepest layer and outermost layer of the human skin. And this cancer forms when the mutated Merkel cells start to rapidly grow and divide out of control. Because this type of tumor is highly metastatic, spreading to other parts of the body faster than other cancers, survival rates are unfortunately low, with over half of the patients diagnosed with Merkel cell carcinoma dying from the disease within 5 years of diagnosis. Merkel cell carcinoma is commonly diagnosed in people over the age of 65, with an average age of diagnosis being 74. Over 90% of the cases are started on areas of the skin that are frequently exposed to the sun, which include both the head, neck, and the arms. And here we have some information about risk factors and screening for Merkel cell carcinoma. Remember that most people do end up contracting Merkel cell polyomavirus during childhood because most people end up contracting this at some point in their lifetime, and 90% of the population have antibodies. There are not any definitive risk factors for getting the virus, and most people who are infected do not end up developing Merkel cell carcinoma. There are several risk factors for Merkel cell carcinoma, not Merkel cell polyoma virus, but the risk factors for Merkel cell carcinoma include having sustained Merkel cell polyoma virus infection that is reactivated within the body. They also include excessive sunlight and UV radiation exposure, and this can be for people who live in sunnier climates. It also includes having a weakened or compromised immune system, especially in people living with HIV or AIDS, people who have received organ transplants, or people who are living with any autoimmune diseases. And following Merkel cell carcinoma, we have some key takeaways for the information shared about the infectious agents that we discussed today. So, infectious diseases affect nearly all sexually active people, regardless of the number of partners, sexuality, or gender identity. Several infectious disease vaccines are cancer prevention vaccines, excuse me. Talk to your healthcare provider about what screening tests you should be receiving, and follow safe sex and proper hygiene practices, including hand washing, reducing utensil sharing, and not sharing food or drinks with people who have already used them or consumed them. And following this, we are going to transition into our post test. So feel free to take a moment and answer the post test, which is the same set of questions that we took a look at for our pre-test. So after receiving the information about the 8 types of infectious agents, feel free to answer whether or not you believe the answers to questions 1 through 4 are true or false. And we'll allow about a minute, and then we will go from there.
Just give it a minute to get at least a good percentage of participation. Come on, if one or two more of you could finish it. There we go. Okay.
Okay, so for our post test, question one, we had the only way HPV can be prevented is by practicing safer sex. 19% of the participants today answered true. 81% of the participants today answered false. And the answer to that question is false. So, another method of prevention, also the primary method of prevention of HPV, also known as human papillomavirus, is the HPV vaccine, which can be administered as early as age 9 and as late as age 45 or beyond if a person is interested. And then from there, for question two, we have HBV, which is also known as hepatitis B, can be transmitted via mother to child during childbirth. So for that one, we have that 94% of the participants answered true. We have 6% of the participants answered false. The answer to that one is true. So HBV can be transmitted via mother to child during childbirth. For question three, we have HIV can be transmitted via bodily fluids. 94% of participants answered true and 6% answered false. That is true that HIV can be transmitted via bodily fluids. And then for question four, we have that there is more than one type of herpes simplex virus, and 100% of the participants answered true to that one. So thank you everyone for taking the time out to respond to our pre and post tests. And thank you, Evelyn and Sarah.
Dr. Gabor, you can go ahead and get started.
Okay, great. Good morning, everyone. My name is Lisa Gabor. I am a gynecologic oncologist in the Department of OBGYN and Reproductive Health at Rutgers, New Jersey Medical School, and it is my pleasure to speak with you this morning about HPV and cervical cancer. Just as an aside, this was already mentioned at the beginning ever so graciously, but I did serve on the American Society of Colposcopy and Cervical Pathology on the board for 2 years, and I'm currently involved as the one of the program directors for the scientific meeting. Today, I hope to cover a couple of different things. So we're going to take a deeper dive into human papillomavirus and its role in cervical cancer development. We're going to talk about a patient of mine, as well as the impact of social determinants of health on her care. We're going to discuss current prevention and treatment strategies, best practices, and future directions, and then highlight some of the national and global initiatives, as well as some of the local approaches for elimination of HPV-associated disease and cervical cancer. So Lauren already covered this beautifully, so I will breeze through it, but human papillomavirus, or HPV, is a double-stranded DNA virus. There are more than 200 subtypes described, but as Lauren mentioned, not all of these are associated with the development of a cancer. And in fact, 40 subtypes have been identified as those that are sexually transmitted. And of the sexually transmitted human papilloma viruses, only some of them lead to genital warts and some of them lead to precancerous lesions. There are 12 types that have been identified as high risk. They're denotated below. And HPV-16 is the most common strain identified in cervical cancers in the United States, followed by HPV-18. So very, very briefly, it is well established that HPV is effectively necessary for the development of cervical cancer, with more than 95% of cervical cancers linked to infection with human papillomavirus. The most common oncogenic types, as I mentioned, are HPV 16 and 18. There are over 600,000 new cases per year globally, and these cases disproportionately impact low resource settings and low and middle income countries. This map is an overlay. The first map that you see is a map of the cervical cancer incidence in the United States, and the second map is an overlap of the incidence of people living below the poverty line. And it's just to make the point that cervical cancer is the most associated with poverty of all cancers in the United States. So this is my patient, Anna. Anna is a 41-year-old with no significant medical history who was referred to me for abnormal cervical cancer screening, which was a PAP with HPV co-testing showing high-grade dysplasia, meaning precancerous, possibly precancerous cells and human papillomavirus, though the specific type was not available. And she had a several months history of irregular vaginal bleeding. As I mentioned, her history from a medical standpoint was fairly unremarkable. She had high blood pressure and took medication for that. She reported a history of normal cervical cancer screening, though those records were not available, and she had just moved to the United States not too long ago from the Dominican Republic and had yet to establish care with GYN. She is a single mother. She lives alone with her 2 young children who are ages 3 and 8. I think if you could go back one slide. Sorry. So when I saw her in the office, as Lauren mentioned, typically the follow-up for abnormal cytology, meaning the screening test for cervical cancer, is to follow up with a diagnostic test or a biopsy with colposcopy. And so that's what we prepared to do. However, unfortunately, on exam, she had a large 2-centimeter nodule on the cervix. That was highly suspicious. So rather than proceed with colposcopy with a microscope, we took a directed biopsy of the mass, and on exam, she had no significant other findings. So unfortunately, the pathology came back as a high-grade squamous cell carcinoma, meaning an invasive cervical cancer. And so I'm going to spend the rest of the talk sort of talking about, was this a preventable, event, and sort of hopefully make the case that in some ways it was. So again, not to be repetitive, but primary HPV prevention is the most effective way of preventing the development of cervical cancer with vaccination of all people within the approved ages for vaccination by the FDA. So just to get a sense of the timeline, the HPV vaccine, which was a bivalent vaccine, was first approved by the FDA in 2006 for only female patients or patients with a cervix ages 9 to 26. In 2011, it was approved for administration for male patients. In 2014, the coverage of the vaccine expanded to cover more strains of human papillomavirus. And then in 2018, the approvals were extended for people of all gender between ages 27 and 45. Just a note about the schedule that's suggested below. It was mentioned previously that for people under the age of 15, only 2 doses are recommended. That's because there's a more robust response immunologically to the vaccine before age 15. And it says here in italics, the ideal ages are between 11 and 12, and that's just because it fits nicely into the vaccination schedule. It has nothing to do with vaccine safety at those ages. And again, we'll talk about the Start at 9 campaign. And then over the age of 15, patients require 3 doses to make sure there's an adequate immune response. It's a dose at time point 0, 2 months later, and then 4 months after that. So it's a 6-month process. And part of the support for that is that we know that, first of all, that vaccination is an effective way of preventing persistent human papillomavirus infection, but also early vaccination, so in children, and this stratifies before and after age 17, is more effective at younger ages. This is a graph that just demonstrates that even though we have great data that the vaccine is safe, that it's effective, and even epidemiologic data that shows it does not change the sexual practices of those who receive the vaccine, there's still today a lot of vaccine hesitancy, particularly with respect to the human papillomavirus vaccine. And you can see that there was an initial uptake after the FDA approval in 2006. That's the purple and blue lines at the bottom of the screen exactly, as they compare to the meningococcal and Tdap vaccines, which have much higher uptake uptake close to 75 to 90%. So there's a lot of work to be done to encourage vaccination. Um, So once we talk about screening, this is now secondary prevention of cervical cancer because hopefully we've made the case that vaccination is paramount. So the PAP test, which is colloquially known as the PAP smear, was developed by Dr. Papanicolaou in the 1940s and has led over time to a 75% reduction in the incidence and mortality of cervical cancer since that time, which is really incredible. The addition of HPV testing, which some of us call the co-test when cytology and human papillomavirus testing are done at the same time, has greatly improved the early detection of high-grade dysplasia, meaning the types of abnormalities in the cervix that we truly consider to be a pre-cancer, and was incorporated into the United States guidelines in the early 2000s. So just to sort of drive home how important these interventions have been, in the early 1900s, cervical cancer was the number one cancer killer in people with a cervix, and currently it's 14th in cancer incidence, but the rate unfortunately has plateaued in the last 2 decades. The incidence is decreasing in women in their 20s, which is likely related to the uptake of the HPV vaccination efforts. And then I would be remiss without mentioning multiple times in this presentation that the healthcare disparities and social determinants of health are really important when we talk about HPV and cervical cancer. And unfortunately, we have not seen evidence that they are improving. So the death rates in Black women and Native American women are 65% higher than in non-Hispanic white women, excuse me. As I showed you earlier, it continues to be the cancer most associated with poverty in the US. And more than half of all persons with a cervix who get cervical cancer screening in the US have not been screened or have not had adequate management of their abnormal screening in 5 years or more. Um, and so the first question we have to ask about these disparities is why they're happening. So these studies are restricted to the United States, but they identified a couple of different barriers. So there are structural barriers to screening, which include the cost of screening. For example, there was a federal mandate that required insurance coverage of all screening for cervical cancer, but did not include necessarily coverage for the follow-up diagnostic tests. So patients may get an abnormal result and then can't afford their colposcopy or excisional procedure. Patients cite a lack of time or ability to get to the doctor to have their screening test done or have the follow-up test. Or physicians get an abnormal result and are not necessarily comfortable making recommendations for what to do next, or don't manage those abnormal results themselves, which then creates a barrier to getting to that next doctor. And then they also cited personal reasons. So the exams are uncomfortable, they may be painful, they may be embarrassed to have a pap smear or a cervical exam, and there is a general fear of screening tests. In other words, okay, so I can get screened, but if I have this abnormal result, like how will that impact me? I would rather not know, I feel fine. And so what people have done is they took those barriers to care and said, okay, well, how can I help to bridge the gaps between screening and treatment? And one of those ways is with the introduction of primary HPV testing. So we talked about screening for cervical cancer. We're still talking about screening with cytology with a PAP test. And then we talked about the incorporation of human papillomavirus testing at the time of screening. Well, what if we did human papillomavirus testing on its own? Does that improve our uptake? And the short answer is that it improves our detection of high-grade dysplasia. And the reason for that is we know that HPV is necessary for persistent HPV is necessary for the development of cervical dysplasia, meaning precancer or cancer. It is the presence and persistence, so the lack of clearance by the immune system of HPV that's predictive of high-grade dysplasia. And you get even more information about a patient's risk if you know the HPV genotype. So what strain of HPV is it? 16, 18, or other? Is it 31, 33, 35? And negative HPV results are more reassuring than negative cytology. This graph shows, we get the question a lot, well, if 95% of cancers are associated with HPV, what about those other 5%? Are we going to miss people? And the answer is maybe. A human papillomavirus test alone is insufficient to diagnose a cancer. Of course, you need a diagnostic test, but from an epidemiologic and cost perspective, as well as a patient access perspective, which I'll talk about in a moment, it's really felt that the number of cases of high grade, meaning precancerous cells on the cervix, is exceptionally low with HPV testing alone. And so one of the nice things about human papillomavirus testing is it doesn't require a skilled procedure to do. In other words, a PAP test requires that you are disrupting cells on the ectocervix. So someone has to be looking at the cervix and taking a swab, at least for right now. And so what if patients could do the testing themselves? If we're using HPV only testing, the hope is that we would reach unreachable patients. So patients with issues with childcare, work, transportation, or other barriers coming to the clinic could be mailed a swab inserted at their leisure into the vaginal canal with specific instructions, and then mail that back. It would be, in theory, and as this has been tested, it would be sent with a return addressed envelope with postage already paid. And then they would be called with results. In post-colposcopy surveillance, so the current guidelines for management of abnormal biopsies require patients to have multiple follow-up tests at much closer intervals than just routine screening. And it becomes a burden. Sometimes it's every 6 months, sometimes it's every year. And especially for patients in rural or remote areas of the US, if that could be a mail-in test, one would hope that it would improve compliance and access. And we talked about increasing screening for people who have barriers to attending clinic. Another sort of movement to improve access and compliance is that the American Society of Colposcopy and Cervical Pathology, which is the organization in the United States that gives it evidence-based instructions for what to do with abnormal screening results. They dictate the management guidelines for abnormal cervical cancer screening, have changed their approach to risk-based approach with the hope that our highest risk patients are being encouraged to are being approached as high risk, in other words, excisional procedures and diagnostic testing, whereas our low risk patients are being told, you have time. We can rescreen you in a year. We can decrease your screening interval to hopefully catch dysplasia earlier, but help you avoid having an invasive procedure that's probably not necessary. So another way of saying this is that if their immediate risk of precancer exceeds a threshold, then they get a colposcopy, the diagnostic test. If it's an even higher threshold, their risk is determined to be even higher. We can go directly to treatment and skip colposcopy because the risk of having a precancer there is upwards of 60%. But if your risk is below a certain threshold, then let's skip the invasive procedure. You won't have to take a day off of work, and we can screen you again in the next predetermined interval based on the guidelines. So the HPV, these are some of the national and global initiatives that exist. These are just some of them, because cervical cancer, hopefully we've made the case, is a preventable cancer, largely through vaccination and appropriate screening. And so the WHO and the federal government in the United States published the 90-70-90 campaign to eliminate cervical cancer with the goals listed here, so that 90% of girls or persons with a cervix will be fully vaccinated with HPV vaccine by the age of 15. So that meets the whole schedule, right? And it's 2 doses rather than 3. So from a patient access perspective and a global view perspective, right, we're saving additional doses for patients elsewhere. The 70% is that 70% are screened appropriately with a high performance test by age 35 and again by age 45. So that's not even saying adhering to the most up-to-date guidelines, which suggests screening every 5 years with HPV based or co-testing. We just want 2 tests in that time. And then that 90% of women identified with cervical disease, so precancer or cancer, received treatment, whether that's a diagnostic excisional procedure with a LEEP or a cone, or treatment of invasive cervical cancer. The Healthy People 2030 initiative is a related initiative in the United States that had over 300 core objectives, but included increasing the proportion of females who get screened for cervical cancer. And then in New Jersey and at Rutgers, we're very proud to have local initiatives. So the Start at 9 or call to action, or the Start at 9 campaign, was mentioned earlier. This is the idea that why are we waiting until age 11 to vaccinate for human papillomavirus? We can start at age 9. This initiative was trialed, I want to say about 5 to 7 years ago, and was highly successful in healthcare settings. So an increased uptake of the vaccine and decreased vaccine hesitancy and required education of the healthcare providers. The NJ Health and Screen NJ we've talked about already, so I won't go into those. There's the NJ HPV vaccination action team, excuse me. And then through Rutgers Health and at University Hospital, we have an event annually called the C-Test Treat program, which is run through the Department of Pathology, where patients can come and get without insurance, without any sort of documentation. They register, they can have cervical cancer screening that goes directly to a provider for follow-up. They then can get a mammogram, they can get Cologuard for colon cancer screening, all on the same day. So I don't want to leave you hanging about my patient. She had imaging she had imaging after I saw her, which only demonstrated disease in her cervix. She ultimately underwent a radical surgery, which included removal of the uterus, tubes, ovaries, and lymph nodes, and then met criteria for adjuvant therapy. So she got adjuvant radiation and did very well. She's now 2 years without any disease, which is great. So briefly in conclusion, I don't want to say that we're doing terribly. We're not. There have been huge improvements made in cervical cancer detection, or cervical precancer screening and detection and prevention in the United States. And the mortality of cervical cancer in the US is much better, especially compared to low and middle income countries, because of these broadly available prevention services, but disparities remain, and we have a lot of work to do. And then the barriers that we talked about that are being slowly addressed, obviously will need to be addressed for quite some time. It is impossible to know how current changes at the national level are going to impact these wonderful programs and vaccine efforts, but I guess time will tell. And cervical cancer screening is transitioning to HPV-based screening. That is coming. How soon, we don't exactly know. It'll likely be you can choose your own adventure pathway, where management options will be available for both. And hopefully self-sampling will fill a void for improving these difficult to reach populations. There was a very large study published in the New England Journal in the last month that demonstrated acceptability by patients and accurate results. I want to give a brief shout out to my division, the Division of GYN Oncology at Rutgers, New Jersey Medical School. We have 3 providers. We're soon to be onboarding a 4th in the fall. We have Dr. Nancy Zoe, myself, and Dr. Anna Turgis, who's our division director. Among the 3 of us, we speak Mandarin, Spanish fluently, and English. I'll let you. I unfortunately only speak English, but I'm very good at using the interpreter line. But we provide comprehensive cancer care, meaning all of our own surgery, all of our own chemotherapy, end-of-life care, and counseling for all of our patients. We see patients here at University Hospital in Newark and in Jersey City as an outreach clinic effectively. And that's how to get in touch with us if you need us. And thank you so much. Please, I'm happy to answer any questions. I see there are some in the chat, and um,
Yes, we have, I believe there's at least two questions in the chat. The first one, HPV may remain dormant for years and not be detected by tests. Is that true? How come the HPV or PAP testings can detect dormant virus or samples taken?
it's a great
Yeah.
question, and we know from what Lauren said that H infection with HPV is nearly ubiquitous. So almost all persons with a cervix will be infected with HPV over the course of their lifetime, especially in the absence of vaccination. Um, it's really impossible to know whether or not HPV is not being picked up because it's not there, because the viral load is too low for the test to pick it up on the threshold, or because it is, quote, laying dormant. But it's felt that the active viral shedding, meaning the active replication and incorporation of the virus into the DNA of the cell um, of the host, is what ultimately leads to cancer. So probably these these the normal test result, which indicates one of those three options, right, either dormant or quantity below a threshold or absent, are less clinically important because we're not picking them up. So if they were there in a larger quantity, we would pick it up, and that would then triage to testing.
So, Dr. Gabor, that would be like, I know somebody who was in their 60s and for the first time ever got diagnosed with HPV. So it was basically
Exactly.
laying dormant, and then something in their immune system had it
Exactly.
come
Exactly.
big. Okay.
Right. Right.
We have another question. Is the LEAP more invasive procedure?
So a LEEP is a loop electrosurgical excisional procedure, and it uses electrocautery, so electricity through a wire, to help shave a portion of the cervix. So it is more invasive in that it's a procedure. It's not a pap smear where we're disrupting cells. We're not really removing them. It's considered a minor procedure in the scope of intervention, but it is a procedure.
Okay. And then the next question you answered in your presentation about the chances of self HPV test and PAP testing and detect accurately HPV cervical cancer. What we're seeing now with the new federal cuts, it looks like a lot of rural hospitals and clinics will be closing. So I guess the hope is that this self-testing the people in those areas that may not have immediate access to someone can do that self-testing. But then I guess then what happens if there's a positive or
Exactly. So that's the hope, is that you reach people for screening. And again, just mentioning how important HPV vaccination is. But you reach people for screening, but the issue then becomes, well, what do we do with an abnormal result? So human papillomavirus positivity alone um, is not sufficient for diagnosing a cervical precancer. You need that cytology, in which case the triage for positive results would be that they need to come in for an office evaluation. And as you mentioned, when these federally funded clinics or these rural clinics are being dismantled effectively, there are fewer and fewer providers who are comfortable performing a pelvic exam, and at bare minimum, let alone a pap smear, colposcopy, et cetera. We live in a fairly medically dense part of the country, so it is less likely to impact the majority of people with a cervix where we live. But again, for patients without insurance, for patients where there's a language barrier, it's going to be a really big problem.
Last question. Do we know if labs are processing those self-tests universally, and how they are being contracted?
Yeah, that's a really a very good, very sophisticated question. I'm not well versed on which companies, which HPV tests are approved for HPV only testing. Um, but um, but it will require an overhaul of like healthcare systems workflow. Um, So I can't answer the question, unfortunately, but you're right. Not all HPV tests are created equally. Not all of them will be acceptable for HPV only testing. And that will be something healthcare systems have to buy into in order to be to participate in self-sampling or primary HPV testing.
Okay. Thank you so much. Thank you both. This was excellent. And thank you everyone for staying. I apologize it ran a little over, but as you can see, it was well worth it. It was excellent, both the presentation on infectious agents and the case study. I'm going to just tab through very quickly through our NJ seed. As you know, Sarah put in our survey in the chat. Please, if you haven't done so yet, click the link. And then for the recording, please go to Mighty Networks. If you haven't joined, you can register online. And then our next session is going to be on prostate cancer on August 13th. But thank you, everyone. This was excellent, and have a wonderful day.